Dr. Schweiger, I'm going to, do you all want to see the MAR again? Or to revisit something with, I'm going to represent the medication administration record and ask you to re-review all of the dosing adjacent to the extubation in this case.
Yes, ma'am. I'm ready.
Thank you. Would you like to revisit any of your answers with respect to the amount of medication offered and administered to this patient?
Yes, so the first round of medications that was given at 10:57 included 1,000 mics of fentanyl, 10 milligrams of Dilaudid, and 10 milligrams of Versed. And then the medical administration record indicates that 19 minutes later, would have been at 11:16 p.m., the same round of medications were given, including 1,000 micrograms of fentanyl, 10 milligrams of Dilaudid, and 10 milligrams of Versed.
Thank you. Doctor, would a reasonable and prudent critical care physician trained in anesthesia know the effects and the combination or the combination of effects of the drugs employed in this case?
Yes, a reasonably careful and prudent anesthesia and critical care doctor would know the pharmacology of these three medicines, both individually and when combined collectively, as well as the doses at which these were being given.
Is there any legitimate medical reason for these doses?
No, given Mr. Hayes's presentation to the hospital, his lack of neurological improvement during the 2+ days that he was at Mount Carmel West, there would be no justifiable medical indication to give these medications at these particularly elevated doses to Mr. Hayes in preparation for or during the terminal extubation process.
Doctor, at what level of anesthesia would be appropriate?
So given that he had essentially 0 pain scores and a Glasgow Coma scale of 3 preceding this, very low doses of opioid or narcotic would have been indicated. Again, probably on the order of 2 milligrams of morphine, or alternatively 1 milligram of Dilaudid, or alternatively a maximum of 100 micrograms of fentanyl. Certainly, I don't believe any reasonably careful or prudent anesthesia critical care doctor would have given 2 opioids at the same time to Mr. Hayes. Again, given his situation, 1 would have been appropriate, and then careful observation and, if need be, incremental dosing of that 1. But there'd be no reason to give both fentanyl and Dilaudid to the patient.
Doctor, would you like to see the autopsy report and toxicology report for the anti-mortem blood again?
Yes.
Can you tell us what substances that could qualify as a narcotic, opioid, or opiate appeared in the toxicology report for Mr. Hayes?
Yes, so on the first page of the toxicology, they indicated that there was fentanyl found, and then also that there were generically opiates found. And then on page 2, They indicated that there was some element of ethanol. Of course, that's not related to opioids. They found cotinine, which is a metabolite of nicotine from cigarettes, in his blood. They did find that there was morphine present. They found the naloxone, which was the reversal agent given by EMS. And then they found carfentanil, which is a metabolite of fentanyl, in his blood. Although it wasn't quantified, they just said positive on the toxicology report.
Thank you. Knowing now the contents of this toxicology report, does that affect your opinion in this case?
No, ma'am, it does not.
Why not?
Again, because what would indicate both the need for opioids at the time of terminal extubation and withdrawal, as well as the dosing, would be the patient's clinical presentation leading up to that decision, meaning how the patient was presenting in the intensive care unit, what his Glasgow Coma scale was, what was the observed pain scores. Those are the determining factors at what dosages you would prescribe pain medication for the patient at the time that the decision was made to terminally extubate and or to withdraw support.
Thank you. In your opinion, did the dosing offered or administered to Mr. Hayes hasten and or cause his death?
Yes, in my professional opinion, within a reasonable degree of medical certainty, both the choice of the three medications that I listed, the fentanyl, the Dilaudid, and the Versed, as well as the excessive dosing of those three medications, and then the decision to repeat them, did cause and or contribute to the death of Mr. Hayes on April the 4th. Of 2017.
Thank you. Was there any legitimate medical reason for this dose of fentanyl or these doses of medications?
No. Given what is documented in Mr. Hayes' medical record, and particularly the observation of the nursing staff as to what his pain scores had been, as well as the physical examination and documentation of neurological exam, I can not come up with any medical justification for the decision to choose these medications at the time of the extubation or the dosing schedule that was applied to each of the three medications. And certainly, given that the medications had just been administered at 22:57, there's no reasonable explanation for why a decision was made to then repeat the dosing 19 minutes later.
Thank you. What purpose could this dosing serve?
Within a reasonable degree of medical certainty, the purpose of giving these three medicines in combination at the doses they were ordered would serve to essentially hasten the patient's death and demise after the breathing tube had been taken out, given that it would more likely than not, within a reasonable degree of medical certainty, result in the patient to rapidly stop breathing due to central apnea, and would most definitely impede or impair his ability at the brainstem level to respond, both to an increase in his carbon dioxide as well as a drop in his oxygen level. He would physiologically thus be unable to respond by triggering breathing, and it would then result rapidly in his death.
What actions or lack of action by Dr. Husel speak to his intent in this matter?
So once again, the lack of appropriate inclusion of the various treatment teams with multidisciplinary involvement, the lack of consultation of palliative care, the lack of appropriate documentation in the patient's medical record as to why a decision was being made essentially in the middle of the night to proceed with terminal extubation and withdrawal of support, the lack of a specific order for terminal extubation placed in the medical record, and then the entries in the medical record concerning the choices of the medication, the dosing, all speaks to the intent of Dr. Husel, who ordered these medications and ultimately was responsible for the terminal extubation withdrawal of support.
What do you believe his intent was in this matter?
In my professional opinion, within a reasonable degree of medical certainty, it appears from studying this medical record and the dosing that the intent of Dr. Husel in ordering these medications at these doses was to cause the patient to rapidly stop breathing and thus to hasten his death.
Thank you. Thank you. Doctor, let's turn the page to Beverly Scherzinger. I won't repeatedly approach. I'm holding her medical record, States Exhibit 3. Did you, in fact, review States Exhibit 3, her medical record?
Yes, consistent with the methodology I employed in the previous two cases, I carefully reviewed Mrs. Scherzinger's record prospectively, meaning from the time of admission through the course up until her death.
Thank you. To the best of your recollection, why did she go to the hospital?
So the reason that she presented initially was because she had had a progressive cough that was initially treated as an outpatient with a Z-Pack about a month previously, and she also had had a low-grade temperature. But as a result of that cough, she then had what was described as choking spells, and then she fell, and that resulted in a bruise around her calf. So she was concerned that she might have or develop a blood clot in her leg. So she presented for evaluation, and then she had had imaging of her chest at the Grove City emergency room, and that was suspicious that she might have a cancer, specifically a type of cancer known as bronchogenic carcinoma. So then she was referred to Mount Carmel West for further workup of the possible malignancy and determination as to what treatment protocols could be offered her for that.
Thank you. Did you review her various lab values?
I did, yes, ma'am.
Okay. Could you discuss her hospital course?
Yes, so after she was admitted, the treatment team realized, first of all, that she had other underlying medical problems. Most notably, she had what's known as aortic valve stenosis in her heart. She also had some stenosis or blockage in her carotid arteries in her neck, for which she had previously had surgery on the right. But most notably, they determined that she had a long-standing history of tobacco usage. She had smoked since she was 15 years of age, and that increased the risk that she actually had lung cancer. Also, there is a type of lung cancer which can result in an endocrine syndrome known as the syndrome of inappropriate antidiuretic hormone release, or SIADH. And they were concerned about that in Ms. Scherzinger because when they looked at her laboratory values, they discovered that she had a very low sodium content in her blood. And as a result of that, they needed to work that up as well. So when they determined that, they initiated medical management to try to stabilize her sodium content, but that initially did not work. So they included additional consultants on her case, including the kidney doctor and the nephrology, which is the nephrology consult, to give advice on how to bring that under control. They also included the need for pulmonary to, again, do a bronchoscopy and look inside her lung to try to better identify what type of lung cancer she had, because the CT scan not only showed the mass, but it showed she had some lymph nodes that were swollen and may infer that she had what's known as metastatic disease, meaning the cancer spreading to the lymph nodes.
Thank you. Was there a time when an invasive procedure was discussed and undertaken?
Yes, for Ms. Scherzinger, they had also been concerned, in addition to that which I've already described, that she had some lesions that appeared within her liver. And they weren't sure whether this represented spread of the cancer from the lung to her liver, or if it was just a secondary, unrelated problem. So they had worked her up and decided that rather than attempt to do a focused biopsy of the lung mass, that they would first attempt to biopsy the liver lesions, and that they would do that in interventional radiology. So rather than take her to the operating room and open her up and look at the liver, it can be done under imaging in the radiology department, where they'll pass a needle with the guidance of CT and thereby get tissue. And she did undergo that procedure, but unfortunately, post-operatively, she appeared to experience bleeding, which is not inherently uncommon, because the liver has a lot of blood flow. So when you go in to do a biopsy, that is a known risk that could occur. And as a result of the bleeding, she developed some blood in her abdominal compartment, thought likely due to bleeding from the liver, and she dropped the blood counts as well, which then resulted in her blood pressure deteriorating.
Thank you. At some point, did she go code?
Correct. So the initial hope of the treatment team was that by giving her fluids and possible blood transfusions, that the bleeding on the liver would slow down and she would stabilize. But unfortunately, then what intervened was that she did suffer what's known as a code blue and require resuscitation.
I'm going to place page 18 of your report. There's a comments section about the code. It was indicated patient in PEA. What is that?
So the initials PEA stands for Pulseless Electrical Activity. And what that means in common parlance means that when you look at the EKG, there's still electrical activity on the monitor, so it's not flatline. But when you try to feel a pulse of the patient, there's no pulse. So there's basically a disconnection between the electrical activity of the heart and the heart's ability to beat. And that's usually not directly related to the heart. It means that something else is causing it. And very commonly, it's a cause of bleeding, hemorrhage, shock, or an acute change in the respiratory status. So if you can determine what the cause of the PA is, often you can resuscitate the patient and restore the function of the heart.
Was that determined in this case?
Yes, the cause of her PA appeared to be the bleeding in her belly, which was the hemoperitoneum as a result of the liver biopsy.
And this indicates that she was transferred to the intensive care unit, placed on vasopressors, and an arterial line was placed.
Correct. So she had CPR, she had the breathing tube placed, and then, not unexpectedly, because of the low blood pressure, she was placed on the vasopressors to support her blood pressure. And then they placed both a central line, meaning that they put a big catheter in one of the major blood vessels in order to give her the vasopressors and inotropes, and they also placed an arterial line to draw arterial blood gases and to measure continuously the blood pressure. So as opposed to the cuff, which goes up every 3 minutes or 5 minutes, the arterial line is hooked up into the monitor, so every second you see the blood pressure.
Thank you. Was the code status for this lady eventually changed?
It was, yes.
Okay. And at some point after the code status change, did Dr. Husel order medication for an extubation?
Yes, correct. So again, the code status was changed, I believe, on October the 9th, October the 9th of 2017, and then thereafter there were orders placed for the administration of 500 mics of fentanyl at 11:22 p.m. on October the 9th, and then at the same time, Versed or midazolam 4 milligrams.
Thank you. At the time that the Versed and midazolam, or the fentanyl and midazolam were ordered, had there been any paralytics administered to this patient? I can offer the MAR if you'd like to see it, Doctor.
Yes, may I see the medical admission record?
Of course. In this patient, the MAR is found at page 822 to 862.
Thank you. So I actually, in the MARS, don't see an entry for there, but in my report, I indicate at the time the patient was intubated, the patient was given 200 milligrams of succinylcholine, although I don't see that entered in the MARS.
Okay, where would that have come up in your report?
That was on page 19.
And how do you want to handle that? Do you want to withdraw that as a comment in your report? Or would you like the opportunity over the lunch hour to maybe review more the full medical record?
Okay, is that a question?
I'm asking. It is a question, Your Honor.
No, it's not.
No,
You're giving choices sustained.
Okay. Would you then like to, how would you like to handle that, Your Honor?
Sustained.
Yeah, so
Okay, there's no question
There's no
pending.
question. Doctor, do you have any explanation for why that appears in your report and not in the medical record?
I believe that to be an error in terms of the entry specifically regarding on page 24, the reference to cisatracure and mercuronium.
Okay, so do you want to, do we then assume that you want to delete that?
Correct.
Objection, Your Honor, as to giving her options as to how it
Yeah,
fits into the
wow,
report.
I agree. The jury can make whatever determination they want. They're the ones judging the credibility of the witness.
Thank you. Have you reviewed the medications that may have been given to this patient during her procedure of 10/9?
Yes, at the time that I wrote the report, I did review the medication.
I'm relating...
Wait, I'm sorry. Sorry, what was the question? Sorry. Could I ask for the court reporter to read it back? With permission from the court?
You may.
I'll withdraw it.
Well,
Yeah. There was an answer, so I just want to make sure I'm hearing the question right.
let's read it back.
Question, have you reviewed the medications that may have been given to this patient during her procedure of 10/9?
That was asked and answered, Your Honor. The witness indicated he had reviewed the medical records in each and every one of these cases, which included the MARS.
Okay, thank you, Your Honor.
So I moved to strike the question and the answer.
You be so strict and disregard the question and answer since he previously answered it.
Thank you. What medications were administered to Ms. Scherzinger at the point of her biopsy?
May I review the MARS one more time?
Of course.
Thank you. So it appeared in the afternoon at around the time of the biopsy, the patient had been given the medication tramadol, which is an oral pain medication, 50 milligrams. That was received at 2:39 p.m. And then approximately 18 minutes later, the patient was given 0.5 milligrams of Dilaudid. And then the patient received a second dose of Dilaudid, or at least a second dose was ordered at 15:12, although at that point the action details again seem to attribute that to the former involvement of the medication that was described earlier.
Thank you. Pain score? Which one? See it posted? Did you review the pain scores?
Yes, ma'am, I did.
Is that what those are?
Yes, so this document is what's called as the direct charting flow sheet that has the pain score starting on October 3rd, 2017, up through the October 9th, 2017 the date of the death. And then below that, there is the category that's called is pain level acceptable, charting for the same period of time. And then on the subsequent pages is listed what form of a pain scale was used in order to document the pain. And then the document will also indicates where the location of the pain was, which in Ms. Scherzinger, it was identified as being essentially back pain.
Thank you. What is your opinion with regard to whether or not Ms. Scherzinger had a salvageable medical condition?
In my professional opinion, within a reasonable degree of medical probability, Ms. Scherzinger most definitely had a salvageable medical condition, given that the abrupt nature of her deterioration was immediately following the liver biopsy, which was done in intervention radiology, and had resulted in a diagnosis that we often treat, which is hemorrhage into the abdomen and anemia. That should first have been addressed to make sure that she was appropriately resuscitated from that. And then, of course, subsequently, once the hemorrhagic shock and hemodynamic instability from that was corrected, then later on attention would have been placed to treat the underlying lung cancer, the bronchogenic carcinoma. But had I been Mrs. Scherzinger's physician, I would have counseled her family that she likely had a life expectancy of approximately a year with appropriate treatment. So again, there was not an immediate possibility of death based on the lung cancer. Again, there were treatment options that she could have been referred to. It was just the abruptness of the liver issue and the subsequent bleeding that caused her condition to rapidly deteriorate.
Did Dr. Husel proceed to order extubation in this case?
Yes, although there was no formal order for extubation, yes, he did order it, and the process of terminal extubation was undertaken.
Thank you. What level of dosing was chosen for this patient?
So in terms of the order that was placed, Dr. Husel ordered on October the 9th in the evening 500 micrograms of fentanyl, in addition to 4 milligrams of Versed to be given to the patient.
Thank you. Is there any legitimate medical reason for this dose or combination dose of fentanyl and Versed?
In my professional opinion, again, within a reasonable degree of medical certainty, given the fact that she just earlier that day had suffered significant bleeding from the liver biopsy and deterioration from hemorrhagic shock, there is no indication to give fentanyl at this level of dosage, nor to give the Versed, particularly since even prior to the biopsy, the vast majority of her pain scores were very, very low or non-existent. There would be no clinical reason to give these dosing, particularly since she had required the addition of both Levophed, the vasopressor, and epinephrine, adrenaline, to resuscitate her after the code blue. Then more likely than not, these medications would have a deleterious effect on her ability to sustain respiration moving forward.
Thank you. In your opinion, did the dosing of the fentanyl and Versed hasten and/or cause her death?
Yes, in my professional opinion, the administration of fentanyl at this dose, 500 micrograms, coupled with the simultaneous administration of the Versed at 4 milligrams, given her medical history, which included the lung pathology, which was the lung cancer, and the events that I described earlier regarding the liver biopsy, the bleeding, the shock, and the code blue, most definitely did hasten Ms. Scherzinger's death on the evening of October the 9th.
Thank you. In your opinion, does the doctrine of double effect have appropriate application in the matter of Ms. Scherzinger?
In my opinion, the doctrine of double effect is not applicable to Ms. Scherzinger because, again, there was no attempt at appropriate moderation, meaning giving the patient medications at a lower dose, or at proportionality, meaning to essentially try to support her and resuscitate her from the hemorrhagic shock that led to the cardiac arrest, and then see whether or not she could be stabilized and from there come out. At a later date then to discuss with her or her family what treatment could be offered for the lung cancer. So again, in this case, the orders for the fentanyl and Versed were excessive and out of proportion with what she had needed prior to that or would need for terminal extubation. So again, it would, in my opinion, professionally be a violation of the doctrine of double effect because the risks would greatly outweigh the benefits.
Thank you, Doctor. What actions or lack of actions taken by Dr. Husel speak to his intent in this matter?
So first of all, I believe the hasty decision to proceed with terminal extubation and withdrawal of support that evening when she just recently had had the deterioration speaks to intent. Again, secondly, the failure to involve palliative care medicine because this is a case where, based on the high likelihood of the bronchogenic carcinoma, there would have to be a discussion about what end-of-life decisions would need to be made. And again, many of these patients can be stabilized and be then eventually discharged to hospice, whether that's home hospice or inpatient hospice, so that option should be given. And then again, a really detailed explanation of the thought process as to why there should be a rapid withdrawal of support, given that her deterioration had occurred simply on that day.
And what is your opinion insofar as his intent?
In this case, based on the totality of the evidence in the medical record, it appears that the intent of Dr. Husel was to hasten the patient's death by the administration of the fentanyl 500 mics, the Versed 4 milligrams, and then the progression to terminal extubation with then the withdrawal of life support.
Thank you. Okay, thank you. Thank you. We are now going to move on to the matter of Danny Millet, which I believe is count 4. Thank you. Doctor, what is the presenting problem with Mr. Millet?
So in Mr. Millet, he had been transferred to Mount Carmel West with an acute change in his mental status. Of importance is the fact that he had underlying significant peripheral vascular disease that affected his legs. So he had developed in the preceding period of time a gangrene of his right great toe, and that had been amputated. So he had been in the hospital and had then been, once stabilized, he was transferred to what's known as an extended care facility for essentially continued treatment of the possible infection and blood flow problems of his lower extremity, as well as to try to strengthen him. But while there, he had this abrupt change that the wife found him unresponsive, and as a result, he was then transferred to Mount Carmel West for evaluation.
And doctor, did you review Mr. Millet's medical record in this matter?
Yes, ma'am, I did.
Thank you. How many days was Mr. Millet in the hospital?
Mr. Millet was essentially in the hospital. He was brought in on December the 5th, and then he was terminally extubated later that night. So in regards to his final admission, it appears he only had 1 day of hospitalization.
Okay, thank you. And what occurred during that hospitalization?
So unfortunately for Mr. Millet, he suffered a series of cardiopulmonary arrests in which it appeared that the infection that had impacted his lower extremity had caused him to go into a septic shock-like state. And then his heart stopped several times, requiring resuscitation. And of course, as part of that, he was then intubated and put on a breathing tube, and he required the use of vasopressors.
Doctor, stop a
Let's
minute.
hold on for 1 second.
I actually don't think I touched anything. Any clue as to?
Well, I'm trying. There we are.
Thank you. Sorry. Could you read back the last question response before the flashing?
Question, what occurred during that hospitalization? Answer, so unfortunately for Mr. Millet, he suffered a series of cardiopulmonary arrests in which it appeared that the infection that had impacted his lower extremity had caused him to go into a septic shock-like state. And then his heart stopped several times, requiring of resuscitation. And of course, as part of that, he was then intubated and put on a breathing tube, and he required the use of vasopressors.
Thank you. Doctor, do you have an opinion as to the scope of his medical problems?
Yes, I have an opinion regarding the scope of his medical problems.
And do you feel that, given the scope of his medical problems, that he had a salvageable situation?
Yes, certainly Mr. Millet was critically ill. He had multiple medical problems that justified admission to the intensive care unit. But again, given the circumstances that there was an identifiable cause and that the cardiologist who was brought in on the case felt that this was not a primary heart problem, but rather secondary to another problem, which in this case was the infection that would have been contained in his lower extremity. And he had suffered abnormal blood chemistries and acid-base disturbances. Certainly, he warranted ongoing resuscitation to see whether or not his conditions could be stabilized, and the multi-organ dysfunction that was determined by the ICU doctor, Dr. Duffy, could in fact be reversed.
Thank you. Did you find indication in the record that this gentleman was experiencing pain or distress?
No, in fact, the opposite. In reviewing his record, and likely because of not only the suddenness, but the numerous cardiopulmonary arrests, Mr. Millet was definitely in a coma. So I would describe him as comatose, and there was no indication that he was demonstrating any form of pain or suffering at the time that he was brought into the emergency room or the ICU.
I'm going to present pain scoring to him. I'm going to present Mr. Millet's pain score information, which appears at 342 to 348 in the MAR. What do you find there, doctor?
What I find is consistent with my prior answer, that Mr. Millet was documented to have a 0 on the pain score. The nurses that cared for him during the day did not find any indication of pain. Also, his Glasgow Coma scale was at 3, the lowest it could be, meaning he was, in fact, comatose. And at the time that he was examined, his pupils were non-reactive. They were 5/5. So again, all of those findings are consistent with a patient who remains in coma. And it was not until the evening of December 5th that there was one entry by a nurse that corresponded with the administration of the medications for terminal extubation, where he was given a 10 on the pain scale. But everything preceding that was a 0.
Doctor, do you feel that this extubation was appropriate?
In my professional opinion, it is my opinion that this extubation at this point in his care was not appropriate, since all appropriate resuscitation measures had not yet been exhausted.
What dosages were offered to him at the point of extubation?
So Mr. Millet was ordered and then received 1,000 micrograms of fentanyl. He received 4 milligrams of Versed, and he also received 2 milligrams of Dilaudid.
Thank you. Was there any legitimate medical reason for these dosages?
In my professional opinion, expressed within a reasonable degree of medical certainty, given that Mr. Millet was clearly comatose, that he had no reaction to either physicians or nurses that day who had examined him, that his pain scale had been a 0, that he had a Glasgow Coma scale of 3, that he was basically demonstrating by all manners of diagnostic ability a coma and comatose, I can think of no medical justification for administering these 3 medications at the dosages that were prescribed by Dr. Husel.
What purpose could this dosing serve at this level?
There certainly would be no medical justification of giving a patient 2 opioid medications when they were in coma and they were not experiencing or documenting pain. Similarly, if a patient is in coma, it would be impossible to assess whether or not the patient had anxiety or fear. So a sedative hypnotic when you're already in a coma is not medically justified. So the only plausible explanation for administering fentanyl, Dilaudid, and morphine would be to hasten the patient's death by interfering with their ability to breathe spontaneously once the breathing tube is removed and the patient is taken off of life support.
In your opinion, did the dosing in this case hasten and/or cause his death?
Yes, in my professional opinion, the administration of 1,000 micrograms of fentanyl coupled with the Versed and the Dilaudid rapidly served to depress Mr. Millet's respiration, and then the concomitant removal of the breathing tube and life support then accelerated his death because he could no longer breathe, particularly given that he had had all those attempts at resuscitation earlier in the day.
In your opinion, does the doctrine of double effect have application in this case?
No. In review of Mr. Millet's record, the doctrine of double effect is not, again, applicable because, first of all, he had not, or the doctors had not exhausted the maximum medical therapy to see whether or not his condition was reversible. And equally important, had not given Mr. Millet enough time to declare whether the underlying conditions themselves were terminal and care was futile. Secondly, since there was no medical justification for giving 2 powerful opioid medications in a patient who previously was clearly in coma and unconscious, the doctrine of double effect would not support then giving these medications because, again, it shows no moderation, there's no reduction in dosing, and it's out of proportion what the patient himself would need for any reasonable or prudent decision to try to avoid pain on terminal extubation, which, again, generally is not painful. And lastly, the administration of Versed in combination with the opioids would more likely than not result in respiratory depression, which again in this situation would not be supported by doctrine of double effect because it would overweigh the risks, that being respiratory depression, versus any potential benefit.
Do you feel that this procedure was an emergent procedure?
No, in studying Dr. Duffy, one of the pulmonary critical care's progress notes, it was clear that a well-established plan of how to support Mr. Millet was entered into the medical record, and they were planning to support him on the ventilator with the current vasopressors and see whether his underlying metabolic condition could be corrected and that he would be reevaluated the next day to then have a multidisciplinary discussion with the family on whether or not life support should be withdrawn. So to move hastily in the middle of the evening to terminally extubate and withdraw support would seem to have no medical justification when the team that had performed the comprehensive critical care admission had clearly laid out the plan in the medical record.
Thank you. What actions or lack of action by Dr. Husel speak to his intent in this matter?
So, first of all, the lack of definitive communication with the admitting and critical care consulting team who had initially evaluated him and had established the plan, and the need for reevaluation on the subsequent day shows intent. Secondly, the failure to obtain appropriate consultation with palliative care, even if that consultation would occur on the next day when there was the plan to talk about the chances of a survivability. The decision to order 2 powerful opioid medications when Mr. Millet was not demonstrating any pain. The addition of the Versed when he clearly was a Glasgow Coma scale of 3 and all his physical findings demonstrated that he was comatose and thus would not be processing any fear or anxiety. And also then the relative hasty decision to proceed with a terminal extubation in the middle of the night when more likely than not it would result in his rapid death all speaks to the intention of Dr. Husel in ordering these 3 medications at the specific dosages they were ordered.
What do you believe the intention was in this case?
In my professional opinion, having studied Mr. Millet's record, the intention was to rapidly terminate Mr. Millet's ability to breathe on his own and thus result in a hastened death after the breathing tube had been removed and life support had been terminated.
Thank you. Dr. Schweiger, let's now turn to the matter of Brandy Mcdonald, which I believe is count 5. What was Ms. McDonald's presenting problem?
So Mrs. McDonald had been diagnosed years earlier with a rare form of ovarian cancer, and that cancer had at the time been found to have spread into her abdomen. So she had undergone a total abdominal hysterectomy and removal of her ovaries, as well as multiple tumor debulkings in order to control the ovarian cancer. She had also been given chemotherapy and had entered approximately a 3+ year period of remission. Unfortunately for Ms. Mcdonald, it appeared the ovarian cancer had returned, so she was enrolled in a new research protocol, and she was given new chemotherapeutic agents, and this is nivolumab, Nivolumab. As a result of that, one of the known side effects is that it can injure the patient's liver. And it is thought that that's what's known as an autoimmune reaction of the chemotherapy on the liver. Autoimmune means the body is sensitized and then sees parts of itself as foreign and attacks it. So there was concern that she was having a liver injury, and thus she was brought to the hospital both to work up the status of her liver, but also to evaluate the remainder of her organs, given that she had some additional medical problems.
Thank you. And doctor, did you review her full medical record?
I did, yes, ma'am.
I'm going to present to you State's Exhibit 32G and direct your attention to the overview comment. On the front page. Is there a typographical error?
Yes. As one would note, I think I used the template, and there is a typographical error. It lists Francis Burke, but again, this is the report for Brandy McDonald, so that was just a typographical error.
Thank you. And is Brandy McDonald's name listed 3 times at the top of the report?
Yes, it's listed 3 times at the top of the report, above where I made the typo, and then on each successive page, it's listed at the top of the report on each of the pages of the report.
Okay, thank you. So, what was Ms. McDonald's course in the hospital?
So initially, when she was brought in, again, the concern was regarding her liver and the fact that she had elevated liver enzymes. And as I noted on page 3 of my report, she was actually a full code, that she wanted resuscitation and she wanted to be supported through that process. As she went through the process, however, she did demonstrate instability, and she had a worsening respiratory component to the point where on January the 14th of 2018, the patient appeared to have a cardiopulmonary decompensation and arrest and required Dr. Husel to place an endotracheal tube and put her on the ventilator. And he had administered 2 milligrams of Versed and 200 milligrams of succinylcholine and was able to successfully intubate the patient. Because there was concern about autoimmune hepatitis, the decision of her treatment team was then to administer high-dose steroids to try to reduce the inflammation in her liver, and that was then undertaken throughout the hospitalization, and she was then going to be started on prednisone 120 milligrams through that. Her serum lactate did increase, as well as her liver enzymes. And at one point, they did send her down for a study because there was concern that she might have emboli in her lungs, what's known as pulmonary emboli. And that was confirmed that she had bilateral pulmonary emboli. And then eventually, she had been on a medication that is used for a lot of people that have type 2 diabetes. It's called metformin. And that medication, oral hypoglycemia, can result in acidosis if the body goes into shock or other problems occur. So she developed a worsening metabolic acidosis, and it was thought that it was likely contributed to by the metformin. So she was then placed on essentially continuous dialysis in order both to control her volume status, but also the dialysis machine could purify the blood and correct the underlying metabolic acidosis.
Thank you. As you review her situation, do you feel that she had a salvageable medical condition?
Yes, within a reasonable degree of medical probability in the short term, which is related to this hospitalization and the impact that the toxicity of the chemotherapy had on her liver, and the fact there also appeared to be impact of the metformin. Clearly, there would have been salvageability to have stabilized her medical condition and, again, allow her to get into a position where then discussions could have been had with her and her family about eventual wishes regarding either home hospice or inpatient hospice. Again, clearly in terms of her underlying ovarian cancer and the metastases, that did paint a difficult situation in the next couple of weeks or months. So certainly that needed to be discussed. But in terms of what actually brought her to Mount Carmel on January 11th of 2018, and then the decompensation, those were all issues that are routinely treated by critical care teams in an ICU.
Was she appropriately placed in the ICU?
Yes, given, first of all, the complexity of her medical problems and the fact that she had been undergoing chemotherapy, those are high-risk patients. Their immune system is impaired. They can easily get infections, so they warrant admission to the ICU, both for surveillance and then for potential treatment. Also, her body habitus, even though that she had undergone the abdominal surgery in the past, she was morbidly obese, and so that also factors in that she benefited from careful observation and treatment. And then, of course, because both her liver and then her kidney were showing signs of deterioration, it was justifiable to have her in the intensive care unit for ongoing treatment.
Was intubation appropriate?
Yes, at the time that Dr. Husel evaluated her, I most definitely support his decision to intubate her. She needed to have, at that point, the tube. Not only was there evidence of multi-organ dysfunction, but as I mentioned earlier, there was this issue about the multiple pulmonary emboli, which again needed support in treatment. So as a temporizing measure and as a measure to provide supportive mechanical ventilation, I definitely support the decision to intubate her.
If she had been your patient, how would you undertake her case?
Had Ms. Mcdonald been entrusted into my care, I would have convened a multidisciplinary panel, most notably with her oncologist who had been guiding her chemotherapy, to fully understand what the prognosis of this ovarian cancer that had had recurrence was, and what the likelihood of this new, essentially, treatment protocol could offer her. Because again, as a critical care doctor, we deal with cancer patients, but we do not administer or manage chemotherapy. So that is really outside of our area of specialty. So we need to get input from the oncologist in terms of both the life expectancy related to this cancer, as well as the treatment, which again, in this case, was advanced. This was specialized treatment. Additionally, getting input from gastroenterology regarding the liver and whether or not the liver could rebound with response to the steroids, and then input from the kidney doctors about the effect of the dialysis would all have been very, very important. So this is the type of patient, given her youth, the fact that she had a relatively young child, and that she had expressed desire for full resuscitation, that I would convene such a conference and have a deep drill down into her medical situation. Obviously, ultimately, the critical care would orchestrate that. I, as mentioned, would also include in those discussions the palliative care team, because it would be important not only to address the short-term prognosis, but then her desire for long-term issues, both in regard to palliative care as well as potential long-term issues of hospice in that setting. And then, of course, I would have continued to support her for several days to see whether her organs showed improvement. if the liver and the kidney continued to show further deterioration and/or her heart and lungs continued to show deterioration, certainly I would have discussed potential palliative care later on, but at the time the decision was made, I believe it was too hasty to conclude that there was no hope for her treatment or support.
Thank you. At some point, was there discussion of going to a DNRCC?
Correct, yes. So then eventually there was an order placed in the chart on January the 14th at 10:13 in the evening to change her status from full resuscitation measures over to DNR comfort care.
Pain scoring for Brandy. Did you review the pain scoring in this case?
Yes, ma'am, I did.
And for the record, the pain score on Ms. Mcdonald is found at page 288 in the medical record.
Thank you.
Thank you. What does the pain scoring reveal?
So from the date of her admission on January the 11th through January 14th, she had a pain score of 0. She had no pain whatsoever described by the nursing staff. Then on the early evening, I believe, of January 14th, there was one entry that she had of an 8. And then that followed a 0. What followed was a 0. And then at the time that the palliative care medications were administered, she had a score of 10.
Thank you. Have you reviewed the medications given to this patient while hospitalized?
I have, yes, ma'am.
Thank you. Is there any legitimate reason for the dosing that was offered to and administered to this patient at the point of her extubation?
No, in my professional opinion, based on the review of her medical records, as well as the fact that she had abnormal liver function and was requiring dialysis and had the underlying problems of her lung, I can think of no justification for the orders that were placed at the time of the terminal extubation. Also, I might just add that earlier that day on January the 14th, there was an order placed by Dr. Husel for fentanyl 50 mics IV every hour, PRN, meaning as needed. Certainly, I am not in any way critical of that order. That was showing a judicious, small, incremental dose that the nurses could have given her if, in fact, that she needed it for pain. So I was puzzled when then later that night I saw that the order for fentanyl at the time of extubation was 20 times that. So rather than 50, which was ordered in the morning, she was then ordered 1,000 micrograms of fentanyl.
Thank you. Who ordered the 50?
Dr. Husel ordered the 50.
Okay. What purpose could this dosing at point of extubation serve?
Well, given that Ms. Mcdonald had little complaints or objective documentation of pain, other than, as I said, the one entry of an 8, the only plausible explanation that I could come up with as to why an order for 1,000 micrograms of fentanyl would be given would be the intent to hasten the patient's respiratory compromise and thus result in apnea, which would accelerate the patient's death after the terminal extubation and the withdrawal of support.
In your opinion, did the dosing at these levels hasten and/or cause her death?
Yes, within a reasonable degree of medical certainty, particularly in review of the medical admission record of prior administration of any form of medications, as well as the order that I mentioned had been placed in the early morning hours of January 14th for the 50 micrograms Q1 hour. I believe that, in fact, the administration of 1,000 micrograms of fentanyl coupled with the administration of the 6 milligrams of Versed did hasten Ms. Mcdonald's death after the breathing tube was removed.
In your opinion, does the doctrine of double effect have application in this case?
No, in studying Mrs. Mcdonald's case, I could not see justification for the doctrine of double effect. Here again, this was a young patient with a young daughter, or young child at least, who had expressed a desire for full resuscitation and had pursued as an outpatient every form of aggressive treatment to try to manage her ovarian cancer and metastases. The fact that she had a known side effect of one of these new experimental anti-cancer drugs would not then invoke the doctrine of double effect, because again, one would want to first give a moderate attempt at management of the patient and proportionally respond. Again, by giving her such an increase in narcotic dose, the 1,000 micrograms, coupled with the 6 milligrams Versed, at the time that her liver was acutely inflamed and not working, it would not be able to handle these medications or metabolize them in any way close to normal. So there would be a prolonged excessive impact of those. So that would violate any application of the doctrine of double effect. And the fact that she had the underlying deterioration in her lung, as well as the fact she was morbidly obese, more likely than not, removing the breathing tube would result in her being unable to breathe. So again, that would violate the rule of moderation or proportionality.
Thank you. What actions or lack of action by Dr. Husel speak to his intent in this matter?
So certainly, in terms of the action, the decision to place an order for fentanyl at 20 times the dose of the prior order would speak to the intent that one was specifically trying to cause apnea and terminate the patient's breathing. Again, especially in the background of the pain scores. Also, the decision to add Versed into the decision, given the fact that she had the liver dysfunction, the renal abnormalities, the pulmonary emboli, would heighten the impact of the fentanyl, because the two of them together would make it more likely that the patient would not breathe and would thus go apneic, and given her limited reserve, would rapidly progress to death. And then again, the lack of action, meaning the failure to convene a multidisciplinary conference, having never discussed her condition with the oncologist who was managing her cancer, not talking to the GI doctors or kidney doctors who had provided support at Mount Carmel to try to temporize her. Those all speak to the intent of the individual placing these orders.
What do you believe that intent was?
In my professional opinion, the intent in this case was to hasten the demise of the patient once the breathing tube was removed, and thus, more likely than not, within a reasonable degree of medical certainty, rapidly result in the death of the patient.
Thank you. Your Honor.
You finished with that?
Do you guys want to address that one issue with Scherzinger, or do you want to do that after lunch?
We can do that after lunch.
Okay.
We need to circle back on a previous patient, but if the
Let's do
court
that
is
after lunch, ladies
ready
and
to do that.
gentlemen. Let's come back at 5 after 1. That gives you an hour. You guys have a wonderful lunch. Remember the admonitions. With that, Mr. Phillips?
All rise.
Have a great lunch, guys. There's probably